I come on to the next reactor of the day, Dr. Michelle Joseph from United Kingdom. She is trauma and orthopedic surgeon. I would like to have your views, ma'am, on the subject.
Wonderful. Thank you very much for the introduction, and it's a pleasure to be here and listen to the fantastic talks that have been given today. Dr. Walton and I have actually made our reactions in the form of a presentation, which we would like to share with you. In addition to some of the comments that have already been made, one area that we would really like to touch upon, in fact, two to be specific, are the policy aspect. And yourself, Dr. Gupta, you have mentioned, Professor Gupta, you've mentioned the importance of this, along with partnerships and the potential for integration. And the specific example we'll be giving today will be the military integration with the civilian trauma system. So if it's okay with you, I'd like to share slides and we can get started. Thank you. So once again, I'd like to thank our speakers this morning who've given us some fantastic insight into trauma systems from the LMIC perspective, the importance of data, and the overarching thing which we would like to draw out of that is the need for policies and the importance of partnerships in order to achieve the changes and narrow the gaps that we see, the disparities in the delivery of trauma care. We will also talk specifically of one specific type of partnership in the form of civilian military integration. We have no disclosures to make, and we'd like to ensure that the audience are aware that the comments and thoughts that we share are not the views of the Department of Defence or USU, but rather our individual expertise. Policy partnerships, NSOAPs, which are National Surgical Obstetric Anaesthesia Plans, as a mechanism for integrating the elements that have been discussed today by the speakers this morning, and then the integration. So two broad themes have been raised by speakers today. We have heard about the need for injury prevention to be a component of trauma systems, and also the various elements that make up trauma care. These are our broad umbrella terms. We've also heard today that injury represents the largest burden of avertible surgical deaths. It's estimated at a staggering 68%. And although we understand that injury occurs due to a wide range of causes, road traffic accidents have been mentioned today as the greatest cause of burden. And this is indeed true, which has led to various advocacy initiatives, one being the UN road safety collaboration, the importance of collaboration in trying to eliminate this huge burden of injury mortality. What we know from the data is that road traffic injuries actually result in the death of the highest mortality of 15 to 29-year-olds, and actually 90% of those occur in low to middle income countries. And yet these are the countries that have the least developed trauma systems. Professor Stein also stated that injury prevention is a critical component of the trauma system development, and this is just one example as to why. In addition to the UN's initiative, the Sustainable Development Goals have also defined a specific target in trying to reduce the volume of deaths that occur as a result of trauma. In fact, the goal is to reduce it by 50% by 2030. To do this, we must have policies in place. That's a critical component of achieving and reaching this goal. So when we think about policy, what we're really talking about is a systems level change. We need to engage at that entry point and in the form of national health plans. So in terms of system level engagement, what we're really referring to is active participation by the appropriate stakeholders and the government really driving this change for systemic change. In fact, identifying the treatment gaps is within the trauma system is really key, and that's been raised by many of our speakers today. We know for a fact that surgical care delivery for the avertible burden of deaths, which has been stated in this paper, would be a staggering 52.3 million DALYs if the provision of definitive trauma surgical care was available. This change can only really occur effectively and nationally if it is devised at a policy governmental level. One mechanism of doing this, in order to improve the funding allocation for this systems level change to take place and the technological development, is to engage in the process of developing national surgical, obstetric and anaesthesia plans, of which it is a mechanism for building trauma systems. The components of this, the stakeholders and the partnerships, is what we'll briefly touch on now. And at this point, I'd really like to stress that the NSOPs are a principle that offers some adaptability in guiding the process of providing this safe, timely, affordable trauma care that falls under the surgical obstetric anaesthesia plans. It really offers a roadmap for the national governments and the ministries and the funders and the implementing partners to create an NSOP that is able to exist within a national health policy. I want to recognise Professor Lau's comments, specifically recognising that each country is unique, and the uniqueness of a country has to drive how these processes are developed, particularly when enhancing the trauma system. The example that he gave is that the epidemiology of trauma is quite different to what may be seen in other countries in terms of interpersonal violence being high in numbers, or criminal violence being high in numbers. That's not the case in his native country, but what he had seen is a high rise of a high number of falls. So formulating the trauma system geared towards actually addressing the needs and identifying the gaps is why it needs to be specific to the country. Ministry of Health functionality is also key in terms of there being a centralised or a decentralised system or a regional model. And this is the sort of three categories that NSOPs tend to fall in. Pakistan is an example of a decentralised system, which involves a more federal units and provincial guidance and that have autonomy in determining how the trauma systems function within those geographical regions. In order to achieve this, the situational analysis needs to be performed, and some of these elements have been touched on today in terms of understanding what service delivery gaps there are in terms of standard procedures lists and what definitive management can be delivered at various centres, be it in cluster systems or in trauma systems based on levels. Infrastructure is key in terms of what health facilities are required. I think Dr. Elwala gave us an example of the changes in the facility availability and capabilities, the consumables that are required, the equipment, also the workforce and the shift from specialists and subspecialists. And we've spoken this morning at length about the training differences and prior historical moves from generalisation to subspecialties and why that matters. Governments, looking at the chain of accountability, multidisciplinary teams, monitoring and evaluation, and data. Data has really been stressed today as an important element of identifying the areas for quality improvement. The finance side of things and the funding really leans towards the potential for sustainability and maintenance of care and upscaling of care. Universal health coverage and financial risk protection are really key elements to allowing access. Access has been spoken about today, this morning, in terms of the capacity, the affordability and the safety of the care that's delivered. Mitigating the risk of catastrophic expenditure will undoubtedly lead to improved care and advertible burden. And lastly, the information management with the actual mechanisms for data collection and the importance of registries and morbidity mortality meetings acting as a feedback mechanism for the quality improvement in trauma. Creating these situational analyses, which are done either at the regional level or country level or regions within countries, requires knowing who the actors are in this space. And the delivery of trauma care and injury prevention may be done by many different sectors. By also doing this situational analysis, it serves as an opportunity to form partnerships, and these partnerships are crucial for reducing silos and also effectively pooling and allocating resources. So partnerships can take different forms, and these are sort of 3 examples of trios that occur within our trauma system working space. So development, defence and humanitarian is one group that one could look at, where the nexus in the middle is indeed trauma systems strengthening. There are multiple actors in this space, and they intersect at the very core of trying to enhance the capacity building. Tapping into these resources will ultimately lead to better care delivery, more streamlined care delivery in the country in which we choose to improve trauma. And this brings us on to the next part of this, which is the intersect between military and civilian trauma systems that may exist in parallel, and how potentially integrating those can also lead to better trauma systems strengthening. Academia also sits in that space in terms of global surgery programs that lean towards the planning aspect and policy aspect in developing better trauma care delivery. I'll hand over now to Dr. Walton.